This podcast is brought to you by Meteorate.
Welcome to podcast number 19, folks. We are actually at a different venue here on the wonderful Gold Coast.
We're here together.
With Ziggy, Sarah, here at Meteorate, and our wonderful cardiologist, preventative health guru, Dr. Ross Walker.
Yep.
We are speaking today, later on, Ross, at the Global Business Camp event, and we will achieve a level of mediocrity there never seen before.
Well, you may. I'd speak for yourself on that one.
So that's our motto today, striving for mediocrity in a world of excellence. So some humour to kick off the session, and being on the Gold Coast, more people work out here than probably most places in Australia. Would you say that?
Oh, yep.
So a few little fitness jokes, Ross. Why did the gym close down?
I have no idea.
It just didn't work out. Why did the weightlifter bring a ladder to the gym? Because he heard that he needed to take his workouts to the next level. And Ross, my favourite exercise is a cross between a lunge and a crunch. It's called lunch.
Yeah, well, I can tell you, I entered a swimming contest at the weekend and I won the 100-metre butterfly, but I thought to myself, what am I going to do with such a long insect? And also on the insect theme, but also on the sports theme, this fly lands on the collar and meets another fly of a famous American golfer. And the fly said to the other fly, "What are you doing on this neck of the woods?" There you go.
That's a good
golfing joke.
Just on butterfly, do you know that the butterfly stroke, and I've been getting into swimming again, is the single most taxing human activity, is butterfly. And have you ever tried butterfly, where you bring your arms right around and you've got to have that kick in the right way? It's an amazing... I could do it maybe for 20 metres and then I hyperventilate.
I would have thought spending 5 minutes with a politician was much more taxing, but anyhow, let's move on.
Okay, so medical news.
Yep.
We are no longer living longer.
Isn't that wonderful cadence? We're no longer living longer.
We are no longer living longer.
Yeah.
So that's quite a interesting observation there.
The interesting fact here is that from 1990 to 2011, life expectancy just slowly went up. So if you think about the start of last century, so 1900, the life expectancy was around 50. Now, a lot of that was because of childhood mortality, because of maternal mortality during childbirth, but also in the century, the century of 1900, so the 20th century, we saw the introduction of antibiotics, of vaccines, of all these things markedly improved health and better hygiene, sanitation. And then we found that by about 2011, the average lifespan for a female was about 80, for a male, female was about 84, for a male was 80. Mm-hmm. But they found that since 2011 up to now, the life expectancy is slightly dropping. And they feel the reasons are that there's a marked and progressive increase in obesity. So the true pandemic of the 21st century, diabesity, which leads to abnormalities in cholesterol, blood pressure, and a whole lot of other things we'll be talking about in the next podcast.
Yeah.
And they found that despite the fact that the use of cholesterol-lowering pills and blood pressure pills has skyrocketed, it hasn't reduced this downward trend into life expectancy. So we really need to look about what we're doing with our lives, and what I call the 80-10-10 rule. 80% of anyone's health management is how they look after themselves. It's got nothing to do with damn doctors. We're not that powerful. But people think taking a pill can replace exercise, or taking a pill can replace a good diet. For example, some people go out for dinner and eat more than they normally eat, so take double their Lipitor or Crestor dose to cover that. And that is biologic nonsense.
Yeah.
To give you one example, only 5% of the population have 2 or 3 pieces of fruit per day, 3 to 5 servings of vegetables per day.
Yep.
And those who do have the lowest rates of heart disease and cancer in the community, and it doesn't do zip to your cholesterol. It keeps your immune system healthy. So we really need to rethink the whole concept of health. We have to stop relying on doctors to save us once we've got a problem, and we can just see we're no longer living longer.
And a segue to that, Ross, and I've probably mentioned it before, but we need to have communities that are livable. And also there's all these social problems out there, like with kids too. There's internet addictive disorder, which is something big in China now.
It's big everywhere.
They're staying up, but they don't go to sleep, a lot of young people.
I know that, but I also say our brains were meant to work in 3 dimensions.
Yeah.
So as soon as you bring in a flat screen, which can be a television, a computer, a mobile phone, an iPad, you change the way the brain is wired. And so what happens is that we are meant to think in 3 dimensions, but when people think in 2 dimensions, that's when you see a marked increase in ADHD, autism, other behavioural issues. And I'm not saying flat screens are the cause of ADHD or the cause of autism. But if you are genetically predisposed to these things and you spend more time in front of a flat screen than you do in 3 dimensions, your brain gets rewired.
So is that to do with multitasking? Because they're saying that the multitasking is a myth.
Yeah, there's no such thing as multitasking. It's called sequential processing.
Yeah.
So basically you just deal with the most urgent thing in front of you at the time.
Yeah.
And I think when you look at the term ADHD, what is it? Attention Deficit Hyperactivity Disorder.
Yeah.
What's the attention deficit? They're giving all their attention to a flat screen and to nothing else. And it's really interesting. We've now all moved to Kindles. I own a Kindle and that's a flat screen. But I think it's better to actually hold and read a 3-dimensional book. I think it's better for you.
Yep.
So I think we need to think about that. We need to think about all the things. You and I had a conversation in the car about these e-bikes. And they're just making people lazy.
I know. And that was always a sign that we were advancing. And I'm sure, and I've said it before, that our friends at Google, Apple, Microsoft, the people that design technology, don't sit back and say, oh, we better not develop that because it might have an adverse effect on humanity.
Oh, no, no.
They don't do that.
Oh, no.
It's all about them all.
No, but also, when you look at the people that have the greatest longevity on the planet, and we've discussed the blue zones before, they've never heard of gyms. They've never heard of e-bikes. They actually never heard of exercise because they just move all day up and down steep hills and they eat natural foods and they have a strong sense of community. They don't smoke. And these people have extraordinary longevity. So we need to rethink all these things. Let's move on to the next topic.
Which is future of medicine, newer treatments for asthma.
Yeah, this is interesting because a lot of people with asthma, even though they have their asthma and they carry around their Ventolin puffer and think that's going to be their salvation, they don't realise that asthma is a chronic disease of the lungs caused by chronic inflammation. It is not caused by the lungs going into constriction. That's just the final episode that happens with your asthma. So the management of asthma is definitely never just using Ventolin. That is just outrageous. And so we're seeing a lot of people now as the air gets more polluted and people are putting on more weight because when you put on weight around the belly, you're also getting weight in your heart, in your lungs, in your kidneys, in your brain, in your liver. And so that fat builds up in the lungs. And so when you combine that with recurrent bouts of asthma where you get chronic inflammation in the airways and with that constriction of the bronchi, which gives you the wheezing, people are living their lives and getting used to having asthma, but they're not getting good control of asthma. Yeah. So these very clever people at a place called La Jolla Institute for Immunology have gone deeper into asthma and realised that we've got this thing called the adaptive immune system, which makes T cells and B cells. So the B cells make antibodies that clear up toxins that are in the body, foreign toxins, bacteria, chemicals, whatever. And the T cells direct the B cells what to do, and they make a whole lot of other things called cytokines and everything else. So there's this really lovely interplay from all these immune variants. So what the people at La Jolla have done have found 3 specific molecules. The names aren't really that important, but have developed inhibitors of these molecules. And what these molecules do is code for the T cells continuing the inflammation in the body. So they block that T cell response. So we're getting now very, very targeted treatments to stop the inflammation that's happening in the lungs. And this may revolutionise the treatment of asthma, because at the moment, the anti-inflammatory we use is inhaled steroids and a few other things. But it's the inhaled steroids are the mainstay of therapy. So we're getting much more specific therapies for the treatments of asthma. Where there was also, a few months ago, a new monoclonal antibody that works in a very similar way to this. So we're getting to the point where, whether it's asthma, whether it's heart disease, whether it's cancer, no matter what it is, we'll be able to say, okay, these particular molecules are activated in your case, causing this disease. We're going to block those molecules and stop you from having chronic problems with it.
So historically, swimming's always purportedly been great for asthma, primarily because we do breathe differently when we swim. It's a different process when we exercise. I find that if I swim and race on the bike, that I'm much fitter. And I think I can attribute that to swimming making me breathe differently.
Yeah, there are people called triathletes that actually are rather fit. I think that's a good thing. And I think one of the things for all of us, whether we're asthmatic or not, is we should be performing breathing exercises as well as doing exercise, but specific breathing exercises where you breathe in, you hold it for 3 to 4 seconds, and then you breathe out. And then you have pursed lip breathing, where you breathe in and you breathe out through an obstruction with your lips. So you go like this. And then there's opera singers breathing, and that's why they can hold those notes for so long, because they've trained their diaphragm. So with that, you put your hand on your tummy. When you breathe in, you push your tummy right out, and that pushes your diaphragm down, and that gives you a much greater capacity. But we all should be doing that to keep up our lung capacity.
So are you an asthmatic?
No,
always?
I'm not.
But sorry.
I'm not. But yeah.
Once you're an asthmatic, you're always one.
Yeah, 10%.
And you can't. There's no mature onset.
No, once an asthmatic, always an asthmatic. 10% of the population are asthmatic, but you may not have episodes as you get older.
Okay.
But I'll give you a really important fact here. So this is a fun fact number one for today, is that if you are an asthmatic or you have a history of asthma as a child, and you might have grown out of it, if you smoke with that background history, you have a 100% chance of getting emphysema.
Yes.
So please, any asthmatics out there, if you're smoking, stop.
Yes.
Please just stop them immediately.
And it's a shocking way to
It's a horrible
die, isn't it?
emphysema. It's probably worse than lung cancer, dying from emphysema, because you spend quite a few years on an oxygen concentrator.
Yeah.
Yeah, just even opening your bowels, you're gasping for air. It's just horrible. So please don't smoke. But if you're asthmatic, be under the care of an expert who can manage your asthma properly. But this is good hope for the future of the management of asthma.
Right. So, body of evidence, B12, do we get enough? And B12, what little I know about B12, it's the vitamin that you can only get from animal products.
That's right. So vegans especially get no B12, and so they need to supplement with B12. And one of the most common autoimmune diseases is a thing called pernicious anemia, where you have no levels of B12. And it's a really interesting disease because you get what's called an autoimmune gastritis, or what we call an atrophic gastritis, where the cells in the stomach called the parietal cells make a chemical called intrinsic factor. So when you swallow B12 from animal products, the B12 binds with the intrinsic factor, goes through the small bowel, and the last bit of the small bowel is called the ileum, and that's where the B12 is absorbed. So if you've got pernicious anemia, which means you're just not making this intrinsic factor, you're just not absorbing B12 at all. Sometimes you can have disease in the terminal ileum, such as Crohn's disease, was one example, and then you're not going to absorb B12. And the only treatment is to have injectable B12 every 3 months. But this particular study this is out of the Annals of Neurology from the University of California in San Francisco, and they took 231 patients who average age 71 and measured their B12 levels and did neurocognitive testing, so how much they could think and what their memory was like, and did MRIs as well, and found that the prescribed level of B12 that was said to be safe was probably 4 times lower than it should be. And those who had the lower but normal levels compared with those that had much higher levels had much more neurocognitive decline and much worse changes on their MRI. So the bottom line here is when you have your B12 levels, if they say, oh, I know they're fine, just check where they are in the scale and try and boost them up.
So you'd have to say that most vegans would be B12 deficient.
Oh, yeah. And there's the old joke. How do you know if someone's a vegan? They'll tell you.
And they're neurologically not quite right.
Well, no, we can't say that. But and look, there's a lot of aspects that are very healthy of being vegetarian and vegan. And people, some studies suggest that vegetarians live for 7 years longer than the rest of us. My theory is it just feels like 7 years.
And then we go to the breatharians, people that just live on air.
Oh, let's not go there.
Okay, controversies. Another interesting subject always is calcified arteries.
Yep.
Behavioural change.
Yeah, well, this basic study, and there's been a number of studies along these lines. When you show someone they have a problem, they tend to change their behaviour. So this was only a 12-week study done in Western Australia on the number of people in the study was something like, I'm just sort of checking the notes here. It was done between the ages of 60 to 80, and they found the people in the study. I've got a cough. People in the study, 60 to 80% of people aged 60 to 80 have a degree of abdominal calcification.
Yes.
So they split these people into 2 groups. They told one group about their abdominal calcification, and they just gave the other group education about healthy lifestyle. And they found, interestingly, after 12 weeks, there was absolutely no difference in the intake of fruit and vegetables, other healthy diets and physical activity. But for some strange reason, the people who were told that they had abdominal calcification had lower cholesterols and lower LDLs. Now, the only explanation I can give you there, if they hadn't changed their lifestyle at all, is they probably, if they were on medications, were more diligent taking their medications.
So what's the difference between abdominal calcification and arterial calcification?
No, well, the aorta, the abdominal aorta is just a blood vessel.
Oh,
so it's just one blood vessel that's calcified. But interestingly, when you look at atherosclerosis, so atherosclerosis is a disease that keeps me in a job.
Yeah.
So it's basically the progressive build-up of fat, calcium, inflammatory tissue in the wall of arteries. So imagine a donut with a hole in the middle. The fat builds up in the wall like this. When it gets to a certain level, the body throws in calcium to act as a scaffold to stop it from breaking down. So the problem is not calcium, the problem is fat.
Yeah.
So the calcium is just a marker for how much fat you've got. Yep. So the more calcium you've got, the more fat you've got.
So what's the connection there with you telling someone and there being a build-up?
Oh, no, there's no connection. You're getting it the other way around. You're getting it the wrong way around. Now, what we're saying is when you find somebody has abdominal aortic calcification, then does that change their behaviour? That's what this is about. It's got nothing to do with changing their behaviour because it's calcification. That's nonsense. No.
Yeah.
No, it's whether it changes their behaviour. But interestingly, the technique that I introduced into Australia in 1999, coronary calcium scoring, in conjunction with the Sydney Adventist Hospital and Dr. David Grout, that study, that if people know they've got calcification in their coronary arteries, that'll really set them into action to change their lifestyle, and it also changed their doctor's prescribing habits.
Yeah.
Whereas this is more of an incidental finding when they had this on a DEXA scan for osteoporosis, and they said, oh, by the way, to half the group, you've got some calcification in your arteries, and the other group, they didn't tell them. They just gave them education about being healthier. So what I'm saying is that it really depends on the way the information's explained to people. And also, just because you've got a bit of calcification in your aorta and maybe in your iliac arteries, which is where it starts, and tends to occur in the coronaries and the carotid arteries and the arteries right down into your legs a bit later, maybe people aren't as motivated. Whereas if you've got a coronary calcium score, you say, look, you've got a lot of muck in your heart. if you don't change your lifestyle and you don't take these pills, you're in big trouble of having a heart attack. Whereas a bit of calcium in the aorta, there's not much you're going to say about that. So I really think it's where you're finding the stuff. The carotid arteries going up to the brain, what you do there is an ultrasound, and most people in their 60s and 70s have a little bit of plaque in their carotid arteries. That's pretty normal. But this tells you how much there is, as does the coronary calcium.
So a friend of mine's been told that he's got an aneurysm.
Yeah, that's
in
different.
his artery.
Yeah.
In his groin.
Yeah.
That's
different.
dangerous.
Well, of course it is if it's not treated, but it's easily treated.
Is it?
Yeah. So if you've got an aneurysm, you can have a stent put across the aneurysm. It may be surgery depending on the side of the aneurysm and what it's like. Maybe it's not stentable. So you see, this is the thing that the public get wrong. They think it's either or. They can choose which one they want. Oh, I'd prefer a stent than a bypass, doctor, or whatever. It doesn't work like that. It depends on how the disease looks like to the treating doctor.
Yeah.
And which is the most appropriate surgery. So to give you an example, procedure. The best operation you can have on your heart, if you need one, is to have a left internal mammary artery, which is the artery that supplies the left breast, which in males is particularly useless. But they redirect that artery onto the heart. Now, that artery is immune to atherosclerosis for some reason. Well, I do know the reason. The reason is the internal elastic lamina, or the membrane just inside the inner lining, is much stronger than it is in other arteries. So you just don't get fat buildup in that artery. Yep. So that they redirect that onto the heart, and it'll just see you out. Okay. So people go, no, I'd prefer to have a stent in my LAD than a left internal mammary artery, but sometimes it's better to have the operation because it sees you out. So again, it's the doctor explaining it to you properly, and I mean, there's a wonderful joke about cardiologists. What do they use for contraception? Their personalities, and we need to explain things to people. We need to explain the thinking behind this, and also we need to put things in perspective with the 80-10-10 rule. Yeah, 80%'s your responsibility, not the doctor's. 10%'s medical intervention and procedures, and 10% is, of course, supplements, which I believe in, which most of my colleagues don't.
What's been your experience with some of your patients who've had stents? A lot of people have had stents. It gives them, they think, the green light to not exercise and eat whatever they want. Do they really have a propensity to?
Well, that's not my patients, because my patients get told, you've got stents in now, and the greatest risk for heart disease is having already had heart disease. Yeah. So if you've got if you've got twins, identical twins, they have exactly the same genetic makeup, but one's had a stent, the other one hasn't. The one who's had the stent is probably 10 times more likely to have another cardiac event than the one without the stent, even though they've got the same genes. So if you've already had a history of a stent, heart attack, bypass, and you don't change your lifestyle, and you don't take the prescribed pills, and you don't take the prescribed supplements, you're in trouble, because it's all just going to come back. Okay.
So the stent is sort of something you put in, and it increases the size of the...
Yeah, you just think of it like this. Okay. When you've got any sort of atherosclerosis, you've got disease everywhere, okay? Even though you might have a 90% block in one artery, there's still disease built up in the walls of most of your arteries, just not as bad as there was where that 90% was. So what they do is they put a little hollow tube, which is only a few millimetres along, and open the artery up with a balloon, and then put the hollow tube that sits there and keeps the artery open, and then you grow a new skin along the stent. That's just one part of it. It's
so you can block that very easily with a bad diet, inactivity,
and picking the wrong relatives, and smoking,
and genetically predisposed. Okay, all right, that's great. So, Ross, the topic for this month's podcast is healthy aging and frailty. So, a bit of a prelude. Frailty is a common syndrome which occurs due to a combination of deconditioning and acute illness on a background of existing functional decline that is often under-recognised. Frailty is more common in females, and the risk of frailty increases with age.
Yep.
People with frailty have 2 to 3 times the healthcare utilisation of non-frail people and experience higher morbidity and lower quality of life. Frailty can affect up to 25% of patients aged 70 and over. It can increase the risk of falls, prolong hospital stays, and cause decline in function. It also increases the likelihood of institutionalisation and death.
It certainly does.
Death not good for most people. However, while frailty is linked with getting older, the two do not have to go hand in hand.
Not at all.
Effective early intervention can help people stay healthy and active for longer. So over to you, Bosco.
Okay, well, look, frailty and falls, which go together, are significant concerns, especially amongst, as you say, older people, as they cause all the issues you've just discussed. But it's interesting that below the age of 70, you fall over, but over this age, you have a fall.
Yeah.
And that's the problem. So frailty, it's characterised by a decrease in physiologic reserve, increased vulnerability to stresses, and higher risk of adverse outcomes, especially falls. And basically, research has highlighted that frailty can be identified through various physical and clinical markers such as weakness, slow walking speed, and low physical activities. So now there's a very useful frail scale which goes by the acronym, strangely, frail. Yeah. So for every one yes that you answer, you score 1 point. And if you answer yes to 3 or more questions, you're considered frail, whereas 1 to 2 questions are considered pre-frail. And here's the concern. You mentioned the amount of frailty as people get older, but over the age of 65, it's said that just over 40% of people are already pre-frail, which is a real concern, and they're the ones much higher risk for all of the problems we're discussing. So let's go through the frail scale. Frail, the F, fatigue. Are you tired most of the time? And so many people are just tired and you just can't get their head off the pillow. And then they could have sleep apnea. We spoke about fatigue before, but just answer that one. Are you tired most of the time? Number 1, fatigue. Number 2 is resistance. So can you walk up a flight of stairs unaided or without stopping, or do you have difficulty getting out of a chair? Number 3, ambulation. Can you walk 1 block without any problems? Now that seems to you and me that's ridiculous, but a lot of people still struggle to even walk 1 block.
But just on that, I can walk backwards more than I can walk forwards. So when I walk my 2 dobies, I walk them an hour in the morning and an hour at night, and the bulk of that is backwards. So can we say say backwards is all right?
Backwards is fine.
It's better than forward, maybe? Okay.
The wonderful Monty Python song, I'm walking backwards for Christmas across the Irish Sea. Anyhow, I won't go through the whole song. Number 4 is illness.
Yep.
So do you have 5 or more illnesses? Now you say, well, that's impossible. Well, just listen to this. It may be as simple as having high blood pressure, obesity, diabetes, osteoporosis, arthritis. So there's 5 illnesses for you, just to name a few, and you get 1 point if you got 5 of those. And number 5 is a really interesting one, which is loss of weight. Have you lost more than 5% of your body weight unintentionally over the past 6 months? And so there's the frail scale for you. So that's fatigue, resistance, ambulation, illnesses, and loss of weight. And this is something people don't realise. From age 30, we lose muscle mass and bone mass. So the peak of our lives is 30 and it's all downhill from there. And this is especially so for people who are inactive, where you can lose 3 to 5% of bone and muscle mass per decade, which accelerates over age 65. So at age 30, we have maximum bone strength, and especially after menopause, women for 5 years from menopause onwards, the rate of bone loss can be as much as 2 to 3% per year, and then 1% thereafter. So typically a female loses 53% of their bone mass by age 80. And a recent study published in a journal, BMC Geriatrics, and this is really interesting, a simple but effective method of assessing fall risks in older adults, okay? And what they took was 153 participants aged between 60 to 90. Very simple test. Anyone can do it. You can try this at home. You say, don't try this at home. Try this at home. You stand with your feet together, but the feet just slightly, 1 foot slightly in front of the other, and stand there for 30 seconds.
Yep.
Okay, that's a simple one. But then you do tandem standing where one foot is in front of the other foot. Hold it there for 30 seconds. And then you balance on one foot for 30 seconds and then on the other foot for 30 seconds. Now, for every second beyond the 30 seconds you can do that for, you reduce your risk for a fall by 5% per second over the 30 seconds.
That's interesting because there's a cycling equivalent to that balance. It's called the track stand. So when you see cyclists at lights, there's a track stand where you turn the front handlebars a little bit and you just hold it there. It's very, very hard. Only a few people can actually stay
I've seen people do that.
In the one spot. I can do it maybe for 20 seconds and then I come keel over. But it's interesting from an exercise perspective and frailty. Weight training, not only especially weight-bearing exercise, do help bone mass, but also when you fall, if you've got
muscle bulk,
you can actually absorb that.
Yeah, but it's the same thing. So bone loss and muscle loss, which we call sarcopenia, just goes with the bone loss because you've got to look at it like this. If you're well built, those muscles are also supporting your bones and vice versa.
Yeah.
So it's really important that everyone's exercise should be 2/3 cardio and 1/3 resistance training, whether that is light weights or moderate weights with things like Pilates and yoga as well. So,
but there's an advanced way. There's a good way to fall. You've got to. I mean, when you're on the bike, even though it happens in a nanosecond, if you lose your front wheel, you're down within a nanosecond. But there is a way. Even when you go snow skiing, when you were playing soccer, there's probably a way to fall that's a proper way, even though you can't completely control it.
And what's that? Tell me. I'm waiting.
Well, I'm asking you.
No. I think the best way to fall is not to do it in the first place. It's called prevention. So I think.
But some sports. I mean, you can't say you're going to play soccer and not fall.
No. I know.
And
but
especially if the that's
you don't fall on your outstretched hand. If you can avoid that, because you fracture your wrist.
Yeah.
If you've got a good osteoporosis,
and everything else, I know.
Yeah, I don't do that. But look, falls pose a major risk for severe injuries. Once you've had a fracture, you fractured your hip or fractured something, you're in trouble. Head trauma, of course, which can lead to hospitalisation, long-term disability. And 1 in 3 older adults experiences a fall each year, which I find quite disturbing. And so we really need to look at all those things. And frail individuals may have diminished strength, balance, coordination, and which obviously makes their fall risk so much higher. So you mentioned it so rightly before. We need a comprehensive fall prevention strategies, things like physical therapy to improve strength and balance, environmental modifications to reduce hazards in the home, medication reviews. Now, this is a big deal. Many older people are taking 5, 6, 7 pharmaceutical pills that can drop their blood pressure, make them dizzy, make them a bit disoriented. So there's so many things that we need to do for these people. Look at their pills and have just a coordinated response to all of this. Because if we can reduce people's risk for frailty, we therefore reduce their risk for falls and vice versa.
Yeah, and it's a big area, isn't it?
It's a huge area.
Healthy ageing.
Yeah.
And increasing exercise, improving diet.
Look, as I say all the time, and you don't disagree with me, exercise is the second most important drug on the planet after happiness. And it's so important people have an exercise habit. Yep,
indeed. That was a good one on frailty. Very interesting. So we've got question time.
Sure.
This question is from a wonderful friend of mine who will remain nameless, but who is undergoing some chemo.
Yep.
I think he's got stage 3 non-Hodgkin's or stage 4 non-Hodgkin's lymphoma. And this is his question. Hi, Ross. I'm currently receiving chemotherapy for non-Hodgkin's lymphoma.
Yep.
I'm nearly 69 and prior to this have been controlling hypertension with the daily tablet of irbesartan.
Irbesartan. So did you happen to say the dose? 300 milligrams
/ 12.5.
So he's on irbesartan HCT, so he's got a bit of diuretic in it as well, yep.
To supplement this, I've also been taking ubiquinol active 150 milligram capsule.
Yep.
Prior to my treatment commencing, I had to reveal every pill or supplement that I was taking. Vitamin D got the nod of approval. However, when I told them about ubiquinol, the haematology nurse who was supervising my treatment didn't have a clue as to what I was talking about. What are your thoughts regarding?
Look, ubiquinol is something that I think is very important, and I take it myself just to give me energy.
Yeah.
There's no interaction between ubiquinol and chemotherapy, so he's well within his rights to keep going with ubiquinol. And just because the oncology nurse doesn't know anything about it doesn't mean it doesn't work. It just means she doesn't know anything about it. And this is the problem. There's a wonderful saying: if all you have is a hammer, everything looks like a nail. So you don't think there's anything outside of that. And so if all you have is chemotherapy, that's the only thing that works. And to me, what works, the 5 keys of being healthy: no addictions, good sleep, good eating and less of it, 3 to 5 hours of exercise and happiness, combined with high-quality evidence-based medicine, which is chemotherapy for non-Hodgkin's, but also high-quality supplements. But let me say, to give you an example, there are some, not so much supplements, but food, different types of food that may interact with chemotherapy. And this is where it's important to do the internet search and to discuss it with your doctors, but don't let them just poo-poo it if they don't know it. But I'll tell you a personal story. A distant sort of quasi-relative of mine had multiple myeloma, has multiple myeloma. And she was getting chemotherapy for this, a thing called Velcade, which is highly effective for the sort of myeloma that she had. But what she didn't tell her oncologist, because she thought green tea was very good for her.
Yes, I've heard this.
Yeah, but green tea blocks the action of Velcade. So she was having a bucket of green tea thinking it was good for her immunity, and it is, but it wasn't good when you're taking Velcade. So it is important to do a search to make sure there is no interaction between particular foodstuffs. I'll give you another example. It's got nothing to do with chemotherapy. But many people are taking statin drugs, and especially the fat-soluble statins Lipitor and Zocor, or atorvastatin, simvastatin. They don't do well with grapefruit. A lot of people like grapefruit juice. I personally don't, but a lot of people like grapefruit blocks a particular enzyme system in the liver called cytochrome P450. So if you take grapefruit, you block the breakdown of Lipitor Zocor, and the levels markedly increasing your risk for getting muscle problems on the statins. So it is important when you are taking supplements, and I'm a great supporter of supplements. So ubiquinol is one of the major drivers of the mitochondria. So what are the mitochondria? They're the little fuel packs in cells that drive the cells. So it doesn't matter what car you drive, you haven't got any energy in the car's not going to move. And it's the same thing. If your mitochondria aren't working well, your cells don't work well. Ubiquinol improves mitochondrial action. So I take it every day to give me energy. All my patients on statins, I give them ubiquinol because statins directly deplete coenzyme Q10 in the mitochondria. So ubiquinol is the active version of coenzyme Q10. Ubiquinone, which is standard CoQ10 you'll just get anywhere, is the inactive version, and that's okay if you're 20. But when you hit about 30, and especially when you hit 50, the enzyme diapherase that converts you from ubiquinone to ubiquinol starts to drop right off. And so you're just not getting enough active CoQ10 in your mitochondria if you don't take ubiquinol.
So what's that other version, ubiquicarotine?
Actually, no, ubiquicarinone. That's the inactive one.
Oh, that's the inactive one.
That's
okay.
ubiquinone.
Because I do remember you recommending it.
Ubicarinone.
You recommending it to a marathon runner or someone who had a big.
That would have been ubiquinol. I don't ever recommend ubiquinol.
And what dose would you recommend? Because you said he said that there was a market improvement.
No. He's a marathon runner. He's a very good friend of mine. Before each marathon, he takes 600 milligrams of ubiquinol, not ubiquinone or ubicarinone. That's the inactive one. Forget about that. There's no point taking it anymore when you've got ubiquinol.
Okay. So, and he noticed
significant improvement,
Okay. And when do you take it? An hour or two?
Take an hour or so before.
Okay, interesting. The follow-up question from my friend is, evidently, although, and this is a really hard one to pronounce, obinutuzumab.
Just let me have a look at what it says. That's a monoclonal antibody. So let me just give you these things are the ridiculous names, but that's Obinutuzumab.
That's harder than some of my Greek names.
Yeah, that's it.
Or even the hard ones.
That was taken from a Greek man, that name.
Or some of the Yugoslav names are very hard.
Yeah.
Even though
Obinutuzumab
is the wonder potion,
Yep.
I'm still in awe in how quickly my orange-sized lymph nodes shrank after just one chemo infusion.
Yeah.
One side effect is that it blasts...
By the way, this is not chemotherapy. This is immunotherapy.
Okay.
So it's a monoclonal antibody that targets particular types of receptors within the lymphoma. That's specifically targeted to his type of lymphoma.
I'm the messenger here, like Philippides.
I'm just explaining. I'm the Oracle of Delphi. No, I'm joking.
Or the Aussie would say, I'm just holding the chook, you're rooting it.
Oh, yeah, but enough of that. This is a family show. Listeners, please, that was Homer who said that, not Dr. Walker.
Even although it's a wonder potion, I'm still in awe on how quickly my orange-sized lymph node shrank after just one chemo infusion.
Yep.
One side effect is that it blasts the platelets in my blood count.
Yep.
Transfusion is the only way to immediately boost these platelets, I'm told.
Yep.
Is there a suggested dietary support for platelet growth while I'm on this program?
Tragically, none whatsoever. No.
Okay.
Look, I just think fruit and vegetables, good thing to do. By all means, do that. Maybe take some activated B complex with the fourth generation folic acid, which is the glucosamine salt of 5'-methyl tetrahydrofolate. Maybe about 20 to 25 milligrams of B6 and 500 to 1,000 mics of B12. That will give him some support, but nothing's going to regrow the platelets until the reactions settle down and the platelets will come back.
Yeah. It's interesting how there's all these complementary centres coming up in whatever they call them, not intervention, but complementary medicine, run by GPs and even oncologists over in America.
They're called integrative centres.
Yeah, integrative centres. Yep. And they combine
yep.
conventional medicine with things like IV vitamin C and other approaches.
Yeah, well, interestingly, you should say that.
Yeah.
Because on my radio show recently, it's just another shameless plug for the 9 Radio Network, 6 to 9 on a Sunday night, but it'll be going to 7 to 9 pretty soon when the football starts. The football may have already started by the time this podcast gets to you. So it'll be 7 to 9 Sunday night, healthy living.
Yep.
But I spoke about, wait for this, oral arsenic trioxide. Arsenic trioxide that's being used for a particular type of leukemia called acute myelomonocytic leukemia, which has got a horrible prognosis. 20 to 30% of people die in the very early stages of this disease. And with this oral arsenic trioxide combined with a thing called all-trans retinoic acid, which is actually used for acne, and vitamin C, after 5 years, there was a 97% overall survival and over a 90% leukemia-free survival.
Isn't that amazing?
By all oral treatments combined.
Combination of arsenic and IV vitamin C.
And all trans retinoic acid. No, oral vitamin C.
Oral vitamin C.
Ascorbic acid.
Just, what was the dosage?
I'm not sure.
A few thousand?
Probably about 1,000 milligrams twice a day.
It's amazing. It is, and that's always the dilemma a lot of lay people, if they're confronted with that diagnosis of a cancer. It's always, it always warrants a discussion.
No, warrants a discussion.
Yep.
But never walk away from orthodox medicine.
No.
That really disturbs me that people think, oh, no, I'll just do alternative stuff. And we know that so many people have come a cropper doing that. So I think what works, and I see this certainly in cardiology, my own specialty, but what works is the combination of that 80% lifestyle, 10% medical therapy, 10% evidence-based supplements.
Yeah, there's an interesting film doing Netflix at the moment called Apple Cider Vinegar.
Yeah, the wonderful Belle Gibson. Yeah.
About the lass who faked the brain tumour.
Belle Gibson, yeah.
Yeah. But the real downside to that is that I think they mentioned a certain institute in that film, which is basically raw fruit and veggies and intravenous caffeine enema.
No, that's.
I know, but the downside to that film was that a lot of that stuff is okay and it's very nutritious, but
not the caffeine enemas.
But the raw fruit, the juicing, the beetroot juice, all that.
Terrific for people.
That's really good stuff. But people that once they view that, they think, oh, the whole thing's a scam.
Yeah, but that's like anything.
Yeah,
it's throwing the baby out with the bathwater. You really need to know what works and what doesn't work, which is why I keep saying the final 10% is evidence-based supplements, not just some quasi snake oil stuff that people want to flog you, but stuff that has some science behind it. When I recommend something like ubiquinol, I can quote 20 papers on ubiquinol to how it works.
Yeah,
it's the same thing with the bergamot products that I talk about that I have an association with. My name's on 20 papers for bergamot, and so there's so many things: kyolic garlic, vitamin K2. Magnesium orotate aspartate, just as some examples. High quality multivitamins with the 4th generation folic acid, and a lot of the omega-3 stuff, and vitamin D. I mean, amazing. Vitamin D is an amazing supplement. So
do you think we'll ever get to the stage where that will virtually take over from chemo?
No. What will take over from chemo are these targeted immunotherapies, such as the unpronounceable Orbi, whatever it is that you mentioned before.
But they're almost quasi-natural, aren't they?
No, they're not.
They're not?
No.
So they're all chemicals. When you say
they're immunotherapies that are targeted monoclonal antibodies that are targeting specific receptors that are within the cancer. So this is why we're getting almost personalised medicine. So, for example, breast cancer is 200 different cancers because there's 200 different genetic footprints to cause that cancer. So now you want targeted immunotherapy that's blocking the receptors that's driving that particular cancer. That's what this thing's done for the non-Hodgkin's lymphoma.
So AI may play a role in that too?
AI plays a role in most things these days. Yeah.
Okay.
Quite exciting.
There we go. So on that note, we'll farewell the audience and plug the Seriously Funny Wellbeing speaking package, which will soon be hopefully hitting regional Queensland and beyond in the not too distant future. If you want to go to it, go to seriouslyfunnywellbeing.com. Click on the speaking package there involving Ross, myself, and a lovely chap called Russell White, and that will make your conference the best ever if you are organising a conference. Otherwise, we'll see you next time.
Bye.
Bye.
Hello, listeners in Australia. I've got a big secret to let out about my good friend, Homer Papantonio, the corporate imposter. He's the best speaker I've ever heard. I only deal with the best. He's a great athlete, great cyclist too. And the real reason he's the best is that he uses the best omega-3 supplements on the planet, produced by Zinzino. Homer needs to perform at his absolute best on and off the stage. That's why he takes the best omega-3 supplement on the planet.
Well, yeah, I know about Homer taking Zinzino Omega-3. I've been using it too. It's derived from highest quality ingredients from all natural sources. These Omega-3 balanced oils are molecularly tested for toxins to ensure only the purest and freshest ingredients are used. You can even have a blood test to see what your Omega-3 status is.
Oh yeah, this Omega-3 from Zinzino is the single most scientifically supported supplement on the planet. And the health outcomes are big, really, really big. It's an absolute no-brainer for every man, woman, and child. It's the best, the biggest, and the best. And you can buy it at zzomega.com. zzomega.com.
Like Homer, I've been sucking on Zinzino Omega-3 capsules and solutions for the past year. It helps reduce Alzheimer's and dementia risk, inflammation, mood, improve sleep and immunity, and the list goes on and on and on and on, like you do.
Don't worry about it. Well, Zinzino Omega-3 is the best. I only deal with the best. Go to zzomega.com. That's zzomega.com. Simply the best.